Welcome to the Association of Post-Motor Vehicle Crash Pain and Longer-Term Health Outcomes. We're glad you're here. My name is Angie Hunt, Project Manager with the Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to CIRPD. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Ian Cameron. Dr. Ian Cameron is Chair in the Rehabilitation Medicine at the Sydney Medical School at the University of Sydney. Ian Cameron is a clinical researcher working with people with injuries and older people. He leads an interdisciplinary research and educational unit, the John Walsh Centre for Rehabilitation Research, in the University of Sydney Medical School. One of his major research streams is injury recovery after motor vehicle crashes. And now I'll turn over to Ian.
Thank you, Angie. I'm pleased to be able to present this talk today. We're looking at longer-term health outcomes after motor vehicle crashes with an emphasis on pain. I come from the University of Sydney in Australia, so I hope my accent does not cause you problems. These are our learning objectives. We're going to look at motor vehicle crash epidemiology briefly. We're going to then apply the World Health Organization International Classification of Functioning Disability and Health, and also the Haddon Matrix to motor vehicle crash recovery. We're going to look at strategies to assist recovery, and in terms of recovery, I'm thinking particularly about recovery from disability and participation in life, including work and also quality of life, but also in this talk there's quite an emphasis on pain, and I'm particularly talking about chronic pain. And after this presentation, I hope that you'll be able to demonstrate an ability to apply strategies to assist motor vehicle crash recovery. And finally, so while I'm talking about motor vehicle crash recovery, these principles can be applied more broadly after injury, so with reference to work, sport, or fall injury. So let's just start with an observation. I'm going to refer to guidelines for the management of acute whiplash-associated disorders. These have been developed in Australia, in the state of New South Wales where I work. And these guidelines are used quite broadly by health professionals, but also others, people with injury, and other people who are assisting people with injury. So the statement is, there's strong evidence that high initial pain intensity is associated with persistent neck pain and disability. So we need to think about why this is the case. Most obviously, if there's a severe injury, there will be more severe pain, but that's acute pain. We're thinking today particularly about longer term pain, and the reason why high initial pain intensity is associated with persistent neck pain is that there are a range of other factors influencing that initial pain intensity. So there are psychosocial factors that are operating to lead to increased pain intensity. And so there'll be a lot of emphasis today on psychosocial factors and pain. And to illustrate this, we'll have two contrasting stories that I will refer to on a number of occasions. Note these are based on real people, but they are de-identified. So first of all, we have Mr. A, who's aged 33. He's married with no children. He's got good past health. He's got a high level of education. He's got a university degree. He had a motorcycle crash. He was hit by a vehicle, in fact, while travelling to work, and sustained severe injuries, spinal fractures, including a neck fracture, a C4 fracture, and bilateral ankle fractures. And he has had continuing back pain and also continuing ankle pain, which is worse on the left side. And when seen 12 months after injury, he's got moderate pain, as shown by a visual analog pain scale score of 4 out of 10, and also mild disability with reference to the Neck Disability Index. It's a score of 20 out of 100, and so that would be seen as mild pain. And with reference to other outcomes, he's working full-time. And so his experience is severe injury, but in terms of longer term pain, it's there, it's moderate, and his disability is mild. We think about Mr. B. He's aged 46. He's married with 2 young children. He emigrated from Syria in 2013. He's also had good past health and a high level of education, so he's had university education. He was injured in a motor vehicle crash in which he was the driver. He was stationary and hit from behind, and he's had persistent neck pain, shoulder pain, back pain, and right knee pain. And at 12 months after injury, his circumstances are different. His pain is severe. His reported visual analog pain scale 7 out of 10, and also his disability is severe. Neck Disability Index is 80, and he's unemployed. So it's a really contrasting story. We need to think about why things are different between Mr. A and Mr. B. If we just pause for a minute, I guess, and look at the big picture issues. So motor vehicle crash epidemiology, the World Health Organization is quite interested in this area and produces global status reports on road safety. And the most recently available report is from 2015. The number of deaths globally is very large, more than 1.2 million deaths due to motor vehicle crashes each year. And this type of injury is the leading cause of death in people aged 15 to 29. Costs are very large, about 3% of global gross domestic products. Interestingly, deaths have plateaued, but impact remains substantially greater in low-income countries. And the reason for deaths plateauing probably has been that road user behaviour has been changed and it has reduced deaths and injuries. With relevance to what we're thinking about today, for every death there are at least 20 people who sustain injuries. The deaths and injury severity can be assisted by well-organised trauma services. However, in the World Health Organization report, there is limited recognition of the topic of tertiary prevention. That's limiting the impact of injury after it's occurred. So if we think about the differences between acute and chronic pain, acute pain is a warning signal of tissue damage and in an evolutionary sense is quite adaptive. If we have acute pain, we tend to withdraw from a circumstance if possible to limit further tissue damage. However, chronic pain is quite different. It's pain persisting beyond the normal time of tissue healing, and it's usually seen as pain persisting more than 3 months after injury. It's got high prevalence, and so there's a well-known Australian population prevalence study which suggests that almost 20% of the Australian population have chronic pain. And chronic pain is associated with suffering and disability, as well as being associated with other health problems, particularly depression. And with chronic pain, a specific curative treatment is very unlikely. And that's for a variety of reasons, but the message is that chronic pain is a biopsychosocial experience and needs to be thought of and people helped from that perspective. And so if we look at a conceptual model for recovery from injury, if we think of a recovery as a positive health outcome, and then think of the factors that influence that, the blue box here is the injury itself, but we have other things surrounding that. So in this model, if we think of it as a continuum, all of us bring what's called pre-injury personal factors to our injury experience. And so that might be that we have a past experience in which we were able to overcome injury or disability from another cause, or it might, by contrast, be pre-injury. We may, in fact, already be experiencing disability. And so that will certainly influence what happens after our injury. Inevitably, with injury, there's a psychological response, and that can vary according to the injury. With motor vehicle crash injury, it's unexpected. There may be a threat to life. And so with motor vehicle crash injury, there's likely to be a significant psychological response, and that will influence recovery. And the other factor in this diagram is the compensation system. So injuries sustained in motor vehicle crashes will often mean that the person then is exposed to the compensation system. And while that can be helpful, unfortunately the research suggests that that compensation system exposure is often perceived as a negative by the injured person, and it does seem to have a negative impact on ultimate health outcomes. And so this conceptual model applies the Haddon matrix, which is from injury epidemiology, where it thinks about pre-event, event, and post-event factors. And it also uses the concepts in the International Classification of Functioning, Disability and Health. And we'll have a look at that classification now. So this is abbreviated to the ICF, the World Health Organization. It's been available since 2001, and it explicitly incorporates a biopsychosocial model. So this is a major advance from the model that was present beforehand. And so it's a complicated diagram with lines that have arrows at both ends, so it implicitly implies that one factor influences another factor. And so we have at the top health condition. The middle row has problems with body function and structure, which we might see as impairments, but it importantly emphasizes activities, which is what we need to do in terms of basic daily life to cope. So basic mobility, basically looking after ourselves, basic communication, and other basic daily activities. And then we also have this concept of participation, which is what we do in terms of a wider social role. So in terms of interacting with other people, working, but also using mobility to achieve transportation as we would like. And so it's a broad concept. And the other very important concepts in this diagram are so-called contextual factors. So it's the below the row below. So we have personal factors, which are those things that we bring within ourselves, which include education, gender, probably personality, and then also environmental factors, which includes both the physical environment and the social environment. So environmental factors would include the compensation system. And so then if we think about this with reference to Mr. B, the way this is going to develop implies a linear development of issues, but that's not necessarily the case. I'd stress that all these factors interact. So as we know from before, Mr. B experienced musculoskeletal injuries, and then in terms of his experience, he had pain at the time of injury, and that's continued, unfortunately. He's also got limited lower extremity function and spinal function. He experiences fatigue, and he also has a number of psychological symptoms. So as a result, he has limited walking, and he can't adequately complete his normal daily tasks. His wife is assisting him with some of those things. And then the impact on his broader life is that he's not working, not driving, and his social contacts are quite limited. So he's got some limitations in participation and also limitations in daily activities. And the other things that might be influencing this, I'm just definitely got a query on this. He may have a negative outlook, and his past experiences may have been quite negative and traumatic for him, and so that may influence his current experience after his motor vehicle injury. And the other contextual factor for him is that he finds himself in a system where he's got a compensable injury, so where he sustained the injury, the state of Australia in which he sustained the injury, he has a compensation case, and he has interactions with an insurance company case manager. There's lawyer involvement, which may or may not be a positive thing. And unfortunately for him, he didn't have a supportive employer who was prepared to modify his work role. So that's an illustration of the International Classification of Functioning, Disability and Health. This brief section now is an overview from a study that we have completed that looked prospectively at around 400 people who sustained mild to moderate injuries in road traffic crashes. We recruited them soon after injury and then followed them over time. The headlines from this research are that minor injuries had major impact on pain, physical and mental well-being, health-related quality of life, and return to work and pre-injury participation. So that while the injuries are labelled as minor, they have a major impact in terms of quality of life and economic productivity. And the striking thing was that it was biopsychosocial factors that were the important prognostic indicators of recovery, and explicitly it wasn't the location, type or severity of injury that were influential. We measured biopsychosocial factors in this study as age. In general, older age has some limited negative effect on recovery. Pre-injury health, so poor health and disability influence recovery clearly. Quality of life prior to injury is an influence. Reactions to injury have a negative influence, so that's around catastrophizing and higher initial pain. Social support, if there's positive social support, recovery is better. And in our situation, the third-party insurance system had a negative effect. So how might we tap into these factors at an early stage? There's increasing emphasis on early recognition of adverse prognostic factors, and the Musculoskeletal Pain Questionnaire, now in a short form, is probably the leading contender in terms of identifying negative prognostic factors at an early stage and potentially influencing how support might be provided to the injured person. So this slide might be hard to read, but let's look at what's within the Arebro questionnaire. It includes pain duration, pain intensity, beliefs of the person about what they can do at the moment, whether their sleep is affected, whether there are psychological symptoms, the person's perception as to whether the pain might become persistent, the person's perception whether they'll be able to return to work, and also some beliefs about what is appropriate when the person has pain. So around pain-related activity limitation and pain-related work limitation. So these are scored 10, and some score of more than 50 indicates a higher estimated risk for future work disability. Research based on intervention for people with higher scores as at an early stage, but I'm aware there's at least one study completed but not reported in the literature that shows a more intensive and focused intervention for people at higher risk of disability has a benefit. So now we're moving on to look at strategies in more detail, what might help recovery in terms of disability, pain, participation in life, particularly work, and quality of life. So this is going to step us through an approach to talking to a person, with a person, encouraging self-management of a person with pain, disability, and limited quality of life. And I'll be illustrating it with reference to internet-based resources that are available to me, potentially available to you, and I'll give the reference to those as well. So the first step is to assess the current situation, hear from the person about their experience in a broad sense. There'll also be education and learning about pain at an early stage. And so the pain management network with which I work includes multiple resources. So very commonly, if I can engage with the person with reference to an ongoing plan incorporating self-management, there'll be general educational materials, learning about pain, learning about what helps and what doesn't. And you can see this website's pretty upfront in terms of traditional medical treatments and interventions in the context of chronic and persistent pain as having limited outcomes and substantial risk of harm. So harm minimisation will be an early focus as well. And this is another example through the website, thinking about self-management. It encourages self-management and explicitly looks at aspects of self-management which are involvement in normal activities, using non-drug measures, exercise, psychological techniques, actively problem solving, and then thinking about what are useful thoughts and what are harmful thoughts in the presence of persistent pain. And then, as I said, aiming to reduce harm at an early stage if it's recognised. Unfortunately, that most commonly will relate to opioid use long-term, opioid medication use long-term, but it might also relate to ongoing efforts at diagnosis, which are unlikely to be helpful. There will be efforts at goal setting using the SMART acronym: specific, measurable, agreed upon, realistic, and time-based. And then there will be planning in terms of a pain plan, an initial plan, long-term plan, and review. And depending on the person and engagement with that person, there might be a call for specific techniques such as motivational interviewing and cognitive and behavioural treatments or interventions that are specific in nature. And so in terms of specific techniques, a common one will be activity pacing, so completing the task, realising that there will be some pain, but doing the task possibly in a modified way or possibly over a longer time. Motivational interviewing is well established as a way of working with the person to achieve a goal. And so there are a number of components. It's a supportive technique, recognising the person's current beliefs, but equally trying to support self-efficacy from the person in terms of ongoing recovery and goal achievement. And then in terms of cognitive behavioural aspects, applied relaxation and specific thought management, particularly around fear avoidance and trying to challenge and change catastrophizing beliefs. So we'll move on now to applying these techniques in the context of the two people we've met, Mr. A and Mr. B. So in terms of Mr. A, at least when I think about his circumstances, he's managing well despite severe injuries. I acknowledge that he's got ongoing pain, and I'll try and help him with ongoing self-management. I'll encourage his continuation with his work, but there are accommodations in his work that are relevant. While he does not have a physically strenuous job, he does have multiple workplaces, and previously he's travelled by bus to those workplaces, so it would be involving driving and then limited walking, given the ongoing symptoms he's had. Some analgesia is reasonable, but it won't be opioids. And then his ankle injury is severe, and there is a need for follow-up there because he may develop specific medical problems related to one of his ankle injuries. But for him, at least the way I see it, a more specific pain management program is not required. So this is an example of a man who is recovering well, who's got quite favourable long-term recovery prospects, and the key is to support self-management and not to do anything to potentially damage chances of recovery. By contrast, Mr. B has a variety of complex issues, and I'm the first to acknowledge that helping Mr. B is likely to be extremely difficult. So here, my approach was to encourage self-management, but I personally was not able to achieve that. Mr. B was looking for a treatable cause, and we discussed that a treatable cause of his pain was unlikely to be found, and so the aim was to eliminate or to limit further seeking of those assessments. There was work involved in developing activity and participation goals, so around physical activity generally first, and then thinking about work, while recognising obtaining work while there are lots of complaints of pain and disability is going to be difficult. And it's Mr. B that for which engagement in a multidisciplinary program, if feasible, would be worthwhile. For Mr. B, that is difficult because at least in the situation he finds himself, he's unlikely to find a funder to fund that multidisciplinary program. And so if we think and reflect a bit more on clinical practice, for many clinicians there's limited time to spend with each patient, and so that can limit what's feasible pain management wise. For some people there are perverse incentives in terms of recovery, such as greater disability potentially being associated with greater compensation, or at least a belief as such. Another disincentive is that health professionals may be using a medical model and not supporting health management. So self-management is not something that's recognised by a number of my medical colleagues. And as I said before, there is limited funding for programs that are likely to be more effective. And also the reality is that despite the best efforts, it is not possible to engage with some patients in terms of self-management and an ongoing pain management program. And for those people, the goal should be harm minimisation. So far I've talked about minor and moderate injury. I've also worked with people with extremely severe traumatic brain injury and spinal cord injury. So are they different? Well, in some ways, yes, but in many ways, no. Helping people with these severe injuries with pain also needs a biopsychosocial approach, and psychosocial factors strongly influence the long-term experience of people with these injuries. However, for these people, there is a greater impact of biological. The sort of biological factors that are relevant are the severity of the initial brain injury, as measured by the Glasgow Coma Score, or the duration of post-traumatic amnesia, and also the level and completeness of the spinal cord injury, measured by the AIS scale. However, the principles of pain management programs are the same. Let's just think about the bigger picture for a minute in terms of persistent pain and what helps. Family, friends, the work, the system, and people associated with the system can act as positive factors or potentially negative factors. So the system I'm referring to is, say, case management, insurance system, and others involved with it. So taking a public health approach, can the system be changed? The answer is yes, and there's been some notable examples of how compensation systems have been changed to reduce disability and improve recovery. The most famous one is the report of David Cassidy and colleagues about a change in legislative framework in Saskatchewan. But also I've been involved in a study in New South Wales, Australia, where there was a change in legislation, and as a result people with whiplash recovered better, to a point where we calculated that about 3,000 people per year extra recovered from whiplash in New South Wales as a result of the legislative change. And a further example is that we have yet another legislative change in New South Wales, Australia at present, and within the regulations, as part of that legislative change, there is built-in risk screening with reference to chance of recovery and the ability to provide greater support if the injured person has a prognosis of limited recovery, and also the mandated use of evidence-based treatment guidelines. So we're getting towards the end of the formal presentation, and I hope that the sound hasn't been too bad. So do these same principles apply in other areas? Again, the answer is yes. And so again, I'm using images from the system for chronic pain support, management and treatment in New South Wales. And so chronic pain services take referrals no matter what the background for the pain is, and this is part of the publicly funded health services in the state of New South Wales, Australia, which has around 7 million people. So these are our learning objectives. Hopefully we've covered them. And as I said, now I'll stop and take questions and hopefully have some interaction. So thank you, Angie.
And thank you for your presentation. To our audience, if you have any questions at this time, please enter them into the question and answer box on the GoToWebinar panel, and we'll read them out loud. So questions that come in, where can we find more information on the Haddon matrix?
I think it's best just to Google Haddon matrix. The Centers for Disease Control in the US had some background information.
Okay, so the Center for Disease Control in the United States website?
Yep, CDC, cdc.gov, I think it is, but also just Googling Haddon matrix is likely to produce other resources as well. Okay. So it's used commonly in injury epidemiology, particularly in road safety. It's not so much applied to the type of issue that the type of issues I've been talking about, but it does lend itself to a holistic understanding of the multiple factors involved in understanding recovery. Okay.
The resources in the ACI pain management, are they limited to Australia or can they be used by anyone?
I have not tried to access them outside Australia. As far as I know, they're available to anyone. I hope someone who's on this webinar could just check now and answer that definitively.
Okay. I think that is all the questions. Oh, we had one come in. Can you provide us the links to the articles within your presentation?
Yes, certainly I can do that as part of the resources that will be available after the webinar. Yes.
Okay, yes, and we'll include that in the email response to our audience members following the webinar. So I think that is all our questions for now at this point. Dr. Cameron, is there anything that you'd like to add following your presentation?
No, I don't think there's anything extra. I apologise for the audio problems, and I hope everyone's heard most of what I've said.
Oh, we did have a late question come in. I encounter multiple cases where a client is struggling to engage in CBT due to extremely low mood and struggling to engage in MI due to frustration. Do you know of any recommendations for dealing with this patient?
Well, my approach would be to try and help the person's mood, maintain engagement, and continue to try and work with the person on an ongoing basis. I realise that that's likely to be exactly what the questioner is doing, but that is most likely to be effective.
Another question. Do you have any recommendations for how to motivate team members to switch from medical model to a self-management approach?
That's a good question, actually. Well, I think the way would be to try and engage with the person to indicate where the research and understanding of these issues now is. It's very clearly established that the biopsychosocial model is most effective, and there's enormous research showing that. So I guess I'd say that to the people and try and team members and engage with them. I have those issues with my medical colleagues not uncommonly, and so I'll try and engage with them and try and gradually change their views. But we all have a responsibility to do that, because taking a purely medical model in the context of persistent and chronic pain is detrimental to the person we're trying to help.
Thank you. Well, if you don't have anything else to add, I think that's all the questions at this time. Thank you very much for your presentation, Dr. Cameron.
Good. Thank you, Angie. Thank you to everyone.